Hello, I'm Dr. Payal Kohli, a general non-invasive cardiologist based in Denver, Colorado. I'm also an associate adjunct professor of cardiology at Johns Hopkins University and Duke University. And my passion is really preventive cardiology. And that's because when you're practicing preventive cardiology, you are impacting population health. It's not just that one person in the cath lab, it's not just that one person in the exam room, but it's really entire populations that you're improving the health of. And to me, that's the ultimate privilege as a physician. It's the ultimate dopamine hit or impact that we want to create because we all went into medicine to make an impact. And doing what we do at the bedside makes perhaps the biggest impact. So today I'm going to challenge you to think about secondary prevention in 2025 and really ask yourself the question, are you doing enough? Because we're seeing patients in our office every day that are going on to have recurrent events, recurrent MIs, recurrent cardiovascular events, recurrent cerebrovascular events. And yet we have all the tools in our toolbox, and perhaps we're not doing enough. So I'm going to start by talking about beyond LDL management in 2025. We all know LDL first. We want to get the LDL down early. We want to get it down for longer, and we want to keep it down longer. We now know 55 is the new 70, and for certain select ASCVD patients, 40 may be the new 55 if they're having recurrent events. So the goal of the talk today is not to minimize the importance of LDL, but it's to say that after doing LDL, while we're doing LDL management, we want to start thinking about those parallel pathways, as I like to call them, of atherosclerotic cardiovascular disease. So let's go ahead and get started. These are my disclosures. This is how I think about most of us as we sit in the exam room managing the LDL. We're sitting contented with all that we're doing, getting the patients down to an LDL less than 55. Meanwhile, the world's on fire outside because we're ignoring all those parallel pathways of risk that contribute to atherosclerosis. And I think one of the privileges of being a preventive cardiologist in 2025 is that I now have so many different options that I can offer my patients and so many different ways in which I can prevent an event before it even occurs. I like to say that is us being smarter than the disease. It's us as cardiologists outsmarting the atherosclerosis by targeting these pathways systematically without the disease getting the better of us. So it may surprise you to hear that more than 90% of our country is stage 1 or higher cardiovascular kidney metabolic syndrome. Now, if I said to you that 90% of the country was stage 1 or higher cancer, it would be all over the news. It would be everywhere. Everyone would be talking about it. And yet, we're sitting happily in our exam room while the world's on fire outside, where 90% of our country has stage 1 or higher cardiovascular kidney metabolic syndrome. We know CKM syndrome is a new syndrome coined by the American Heart Association that really comprehensively captures all the different organs, of course, the heart, the kidneys, and the metabolic system, and sees how they all work together. Now, the good news here is that unlike cancer, stage 1 to stage 0 is actually reversible. So you can go backwards if you're stage 1 CKM. So I really want you to start thinking about figuring out what stage your patients are with their CKM syndrome. So the first thing I'm going to talk about today, if we're going to figure out how to put that fire out of the world outside, is who's on fire? How do we figure out which of our patients are the highest risk? And this is what I call finding those target signs. So when I see my ASCVD patients in my clinic, I put target signs on them. The more target signs they have, the bigger the target signs on them, the more aggressive I am about secondary prevention and risk reduction. So let's figure out how to find those target signs and place them in the context of the larger CKM syndrome. We know that prevent equations are the new era of cardiovascular risk assessment. This is an editorial I wrote with some colleagues at Johns Hopkins and elsewhere, really talking about how the prevent equations have ushered in so many different things, so many different epidemiologic trends, including changing risk factor landscapes. So we know that people have different types of risk factors today than they did 20 or 25 years ago, incorporating new trends in cardiovascular outcomes. We're having less people die of NSTEMIs and STEMIs, and more people start to develop heart failure and stroke. ushering in the preventive therapies. We know we're using more statins now than we ever did before, but we have all these new medications, SGLT2s, GLPs, nonsteroidal MRAs. So how does that change risk assessment? And then really shifting that focus, like I said, to not just your heart, but your CKM axis, your cardiovascular kidney metabolic axis, and thinking about what I like to call cardiorenal outcomes. So we're moving away just from cardiovascular outcomes and thinking more about cardiorenal outcomes, composite outcomes that include the kidney as well and include many of the overlapping risk factors like hypertension, diabetes, sleep apnea, and atrial fibrillation. The new prevent equations really do have a lot of advantages over the old pooled cohort estimator equations. They're certainly more contemporary cohort that they're derived from. They include more Black, white, and Hispanic adults, and they have a wider age range. So they actually bring your age all the way down to 30, and it uses many more risk factors. And it's been really calibrated to the fact that we're having lower event rates now because more patients are using statins, more patients are being mindful about prevention. So this results in a broader applicability of the equations. Now they've also incorporated events like stroke and heart failure in the primary composite outcomes, as opposed to just MIs, which was the pooled cohort estimator. And they're tailored both for primary and secondary prevention. This is also very interesting because a lot of times we think we don't really need to risk stratify our secondary prevention patients, but they really do help refine risk assessment even in our secondary prevention patients. And they provide more individual risk estimates as well as better lifetime risk estimates without the overestimation that we sometimes see in the pooled cohort estimator. So lesson number one, when you're putting target signs on your patient, use the prevent equations and get rid of the pooled cohort estimator equation and use these equations to risk stratify. Lesson number two, start to screen for CKM and stage your patient with their CKM stage. So as you're screening them with the prevent equation, you also want to think about checking an A1C, which should be part of your armamentarium anyways, in addition to the LDL. But you don't want to forget about the UACR, which is part of the prevent equation, the urine albumin to creatinine ratio, one of the strongest predictors of adverse cardiovascular outcomes that us as cardiologists often forget to check because it's a urine test. So once a year, per guidelines, you check it on every diabetic, you check it on every hypertensive, you check it on every secondary prevention patient, and you can even think about checking it on your obese patients as well. It's a really dynamic biomarker that works really well. So you're going to assess their lifestyle factors, you're going to assess the A1C, the UACR, the blood pressure, the LDL, then you're going to really figure out what their CKM risk is by putting them into that calculator, figuring out what their CKM stage is. And now you've got a big target sign on them for the CKM stage if they're 1 or higher. And then you make a plan to figure out how to improve their CKM stage, see if you can perhaps even reverse them back down to the lower stage. So that's how you put the target signs on them. Now that you've put target signs on them, you think about these parallel pathways of risk, which, by the way, are additional target signs that you may be putting on them as well, beyond just LDL. So I want you to think about their triglycerides. That's where the icosapent pentethyl comes in. Inflammation and obesity. Two big ones, right? Elephants in the room in 2025 when we've got medications like GLP-1 receptor agonists and of course medications for secondary prevention like colchicine, which we'll talk about as well. I want you to think about lipoprotein A. We know that lipoprotein A is a genetically determined, 70 to 90% genetically determined, 6 times as atherogenic as LDL, certainly a parallel risk pathway. And we're all waiting with bated breath to see what the outcomes trials there show. And then thrombosis is our old friend, right? If that plaque ruptures or you have thrombosis occurring inside the artery because of inflammation and plaque rupture, certainly that can lead to your event as well. So these are the parallel pathways that you're going to think about after LDL, after their CKM staging, to figure out just how many target signs your patient has. So I want to start by talking about the GLP-1 receptor agonists and the SGLT2 inhibitors, which are really the newest secondary prevention drug. And it breaks my heart to say that I have colleagues here in Denver who are cardiologists who have never prescribed a GLP-1 receptor agonist because they still have the misperception that it's a diabetes drug. And that's where I want us to stop thinking about this is the endocrinologist lane, this is the cardiologist lane, this is the primary care's lane, because the CKM syndrome is all one big fat lane. that we are all a part of. And in fact, you'll be surprised to see that there's really good evidence for anti-atherosclerosis with these particular medications. Certainly Serena Williams and Oprah and all the other celebrities that are using the GLP-1 receptor agonists have made it a drug that patients often come into the office asking for. Now, most of the patients that are asking for this may be asking for it because of the obesity indication. But we know that it goes so much farther than that as a secondary prevention drug. So in our patients who have heart disease without diabetes, but they're overweight or obese, we really do need to think about using GLP-1 receptor agonists. And that's the results of the SELECT trial. This was a trial that had standing room only when it was presented because it was just so game-changing to help define this parallel access of ASCVD risk reduction. So what it did is it took several thousand patients, 8,000 in the semaglutide arm, 8,000 in the placebo arm, and these are all secondary prevention patients who already have established ASCVD, and it randomized them to placebo or semaglutide. These are patients without diabetes with a BMI greater than or equal to 27. Okay, look at those Kaplan-Meier curves. I mean, you see nearly an immediate separation of those Kaplan-Meier curves, essentially occurring within weeks for the endpoint of non-fatal MI, non-fatal stroke, and cardiovascular death. These are hard endpoints, right? And you're seeing nearly an instantaneous separation occurring even before the patients have lost the weight. So we realize that it's so much more than just weight loss. Perhaps it's inflammation. Perhaps it's something like plaque stabilization, because we know that in the STOP trial, where we looked at the changes in plaque phenotype over time with a GLP-1 receptor agonist, we know that these medications stabilize the plaque. They didn't change plaque volume, unlike LDL lowering medications did, but they did reduce visceral fat and epicardial fat, and they reduced liver fat. So in these particular medications, we know that they're working through this parallel axis from LDL because they change the plaque in a different way. And as I pointed out, the fact that the curves are separating even before the patients have lost the weight means that it's not all linked to weight, not all linked to metabolic syndrome, and there's so much more at play here. So I want us to start thinking about our secondary prevention ASCVD patients with that GLP-1 receptor agonist target sign and say, do they qualify based on a BMI greater than or equal to 27? And if so, then you really want to think about starting this risk-reducing medication. Because as you see on the left-hand side of the slide here, that both GLP-1 receptor agonists as well as SGLT2 inhibitors obviously reduce major adverse cardiovascular events. But if you look on the right-hand side of the slide, you see all the mechanisms by which they modulate atherosclerosis. And we see that GLP-1 receptor agonists can reduce endothelial dysfunction. They have a renal protective effect. We know that semaglutide, based on the FLOW trial, is indicated in patients with kidney disease and diabetes. They reduce our immune and inflammatory response. And I already talked to you a little bit about what they do to plaque. And then below that, you look at the SGLT2 inhibitors. It's not just about kidney disease. It's not just about heart failure, but these are anti-atherogenic drugs. And you can see here that they do have positive effects on dyslipidemia, on body weight, on blood pressure, on obviously ectopic fat, on endothelial function, as well as inflammatory responses. And they too modulate plaque. So these have to be in your armamentarium in terms of your secondary prevention drugs. So what's looming on the horizon is that we're headed now to triple agonist therapy. Certainly we have dual agonist, which is the GLP-GIP, that's tirzepatide. The cardiovascular outcomes trial is still pending on that. Triple agonist, retatrutide, results in a 25% on average reduction in body weight compared to 20% with the dual agonist, compared to 15% with just the GLP-1 receptor agonist. So certainly there's subsets of patients that are extremely obese or the ones that maybe have metabolic syndrome associated fatty liver disease who may benefit from this triple agonism, but that's looming on the horizon. We're also going to really hope that insurance companies start to come around, because if their cardiorenal outcomes are improved, insurance companies have to follow suit. right? So it's not just a vanity drug. It's not just for weight loss, but it's actually resulting in a reduction in major adverse cardiovascular events, which really needs to be proven with the dual agonist and the triple agonist. And that may help insurance companies to come around. Now, one of the challenges continues to be that the pie is so big, right? There's so many Americans. I just told you 90% of the country's stage 1 CKM that might qualify for these particular medications, either for diabetes, for sleep apnea, for kidney disease, for secondary prevention of ASCVD. So, I'm really talking about a huge burden in terms of treating the nearly 40% of Americans that are considered obese with these particular medications. So what does that really mean for adherence and discontinuation of therapies? All right, so that's the SGLT2s and the GLPs. We talked about the CKM axis. Now I want to talk about lipoprotein A. Now I've got primary care doctors that come to me all the time and say, I'm not checking an LPA because there's nothing I can do about it, right? Wrong. There's plenty you can do about it. And I want to answer the question of, are we there yet, by saying we're absolutely there yet. We really need to start thinking about checking it. We know that there's a global variation of lipoprotein A. As I mentioned, it's 6 times as atherogenic as LDL. It's involved in thrombosis. It's involved in atherosclerosis. It's involved in inflammation. It's involved in aortic stenosis and a whole host of different conditions. And we know that women tend to run higher than men. We also know there's racial disparities, and Blacks tend to have some of the highest LPAs, followed by South Asians, with East Asians having some of the lowest population level LPAs. But we don't know if we don't check, right? It's like having a blindfold on. So how do we know which 20% of us are walking around with this big LPA target sign on us if we don't actually check the LPA? So I implore you to check it in every single patient. In fact, it's now in the guidelines of the National Lipid Association to do so. We know that many of our lipid modification therapies can affect LPA. Statins have a heterogeneity to it. We know that PCSK9 inhibitors in the Fourier trial led to a nearly 27% reduction in Lp(a). We know that inclisiran, which is an siRNA against PCSK9, leads to about an 18.6% reduction in LPA, but we don't follow LPA levels over time. We just sort of check it once as a way to risk stratify the patient today. Now, with the therapies that are coming and looming on the horizon, once we start treating patients with LPA lowering agents, is it possible that we'll follow them over time? Certainly possible to help with prognosis. But here are those therapies that are coming, and they're both in clinical trials right now. So olpasiran, which is an Amgen product, in the OCEAN dose study, led to a nearly 90 to 100% dose-dependent lipoprotein A reduction on top of a background of statins. So 88% of patients and 23% of patients were actually on PCSK9 inhibitors. So, okay, we reduced LPA, but did we reduce major adverse cardiovascular events? And so that's the question that still remains to be answered. Is it safe to lower LPA that much? It seems to be safe based on the phase 2 study. But more importantly, is it efficacious? And do we actually see a reduction in MACE? So that's the phase 3 OCEAN-A trial. That's the cardiovascular outcome study that's pending. And similarly, Novartis also has a product called pelacarsen, which showed a similar sort of reduction. You can see a dose-dependent reduction in lipoprotein A and really no significant increase in adverse events. And here also patients were on a background of statin therapy as well as PCSK9 inhibitors. So stay tuned for what happens if we lower LPA, but what are you doing with LPA today? That's what you need to think about. Okay, so here's what I'm doing with checking LPA today. Number one, I use it as a target sign to reclassify your LDL threshold and your LDL risk. So if your LPA is dose, by the way, the LPA is a spectrum of risk. So a 76 with 75 being normal is not as bad as a 250, right? So the higher it is, the worse it is. We think it's a continuous spectrum of risk. It's not a threshold effect. But if your LPA is high, number one, I make your LDL lower because I'm more aggressive about your other cardiovascular risk factors. I can't do much about LPA today, but I can about the other factors to know that you're higher risk for atherosclerosis. Number two, cascade screening. I screen your family members because it's 70 to 90% genetic. And I have to tell you, the more I look for it, the more I find it. So I have patients where I check one person and then all of a sudden their siblings and their children and everybody else's LPA comes out positive. Number three, there's really good data for patients with elevated LPA to get a primary prevention aspirin. which may improve their outcomes without increasing their risk as much. So they may actually be the subgroup of patients that benefits from a primary prevention aspirin. Certainly, I think about lipoprotein A when someone is going into surgery, because I mentioned to you that it was prothrombotic, and surgery, can affect LPA levels as well. And so you may want to think about being more aggressive about perioperative, DVT prophylaxis, as well as pregnancy, which can raise lipoprotein A. So you may want to think about starting a potentially, a woman who's prepartum on an aspirin 81 milligrams before she conceives, knowing that her LPA is likely to go high up during pregnancy. Of course, this is a discussion to be had with her OBGYN. But like I said, pending those large trials, there's plenty that I'm doing today. And I would implore you that if you haven't already checked your LPA or have any family members who haven't, to go to familyheart.org, order yourself an LPA kit and check it today. Okay, so that's your LPA target sign with the GLPs, the SGLT2s, and the CKM axis. Now let's talk about inflammation. Here's another one of those things that we've had a blindfold on for way too long. And we know that inflammation causes major adverse cardiovascular events in patients with atherosclerosis. In fact, in this study from Paul Ridker, he looked at 31,000 statin-treated secondary prevention patients. And you can see on the left-hand side are patients where the CRP is low, and their risk overall tends to be low. Whereas if you look on the right-hand side, are patients that have an elevated CRP, regardless of the LDL, they have nearly a twofold hazard of having a recurrent event and having cardiovascular death. A nearly twofold hazard. So in some ways, the inflammation is one of the bigger target signs, because LDL we already kind of know of, we're familiar with, but the inflammation is the one that we don't often think about checking. And these are statin-treated secondary prevention patients. The same is true, and this is a sub-study from Paul Ridker as well, if you look at secondary prevention patients following a PCI. Again, on the left-hand side here, you normalize it to patients that have normal HS-CRP, high sensitivity CRP, no significant increase in inflammation, it's less than 2. But on the right-hand side, you see that if your CRP is amped up, it doesn't even matter what your LDL is, your risk is so much higher of a major adverse cardiovascular event post PCI. And that sort of makes sense, because we know that inflammation, prolonged inflammation, can actually be maladaptive, and high sensitivity CRP is a very sensitive marker of vascular inflammation, so to speak. So this is how I'm thinking about CRP today. I break it into sort of 3 or 4 risk categories: less than 1, low risk; 1 to 3, intermediate; greater than 3, high; greater than 10, you need to think about an underlying rheumatologic disorder or something else. So essentially, and these are the new ACC/AHA consensus document that literally just came out this month, October of 2025, that you need to take a look at, when they're now suggesting every person get universal screening with a high sensitivity CRP in the secondary prevention population. So I really want us to take that blindfold off for inflammation as well. Start to check a CRP in all of our secondary prevention patients. Now, let me give you some guardrails about how to check the CRP. You don't check it right after they have a PCI. You don't check it right after they have an infection. You don't check it, right after anything else is going on with them that could cause it to fluctuate. So you want to check it when they're in a stable, kind of happy place as patients. And then you want to repeat it, usually a month or 2 later, to know that it's persistently elevated. And if it is persistently elevated, that's when you put that inflammation target sign on them in terms of what could be increasing their risk. And then you want to start thinking about targeting the inflammation pathway. But here's the other caveat to that, is before you start checking CRP, make sure you've treated the diabetes, make sure you've treated the obesity, make sure you've treated the chronic kidney disease, all the other things that could be leading to CRP being elevated. Because I like to think of HS-CRP as the final common pathway. The inflammation is really how all the CKM diseases express themselves, whether it's fatty liver, whether it's HFpEF, whether it's diabetes, whether it's obesity, whether it's sleep apnea. So go upstream, fix all that other stuff. And if the CRP is still persistently elevated, that's when you think about a medicine like colchicine. Now, the therapeutic window for colchicine is pretty narrow, because you want to be careful not to overuse it. But I want to review some of the data with you that suggests why colchicine may be beneficial in select patients. So this is the LODOCO-2 study, which was colchicine in patients with chronic coronary disease, 5,522 patients randomized to colchicine, half a milligram a day. So this is a low dose colchicine, not what we're usually used to using for gout, which is 0.6 BID, versus placebo. And they looked at major adverse cardiovascular events, and you can see that there was a lower risk of cardiovascular events, a 31% reduction in the hazard ratio for patients receiving colchicine. These are stable outpatients that are doing well. They also looked in the Colcott trial at patients 30 days post MI, and again used that low dose colchicine versus placebo. And here again, you see a reduction, a 23% relative risk reduction in the hazard ratio. Now, of course, there are a few more side effects. Colchicine has gastrointestinal side effects. I mentioned the narrow therapeutic window because you have to be careful about renal disease. It can increase your risk for infection as well, certainly, because it's an anti-inflammatory. So you want to be careful about that as well. So here's how I think about colchicine for secondary prevention. So I'll mention one more thing, which is a recent trial just came out looking at colchicine during the acute MI period, and it was not beneficial. So to me, the idea is colchicine is not so simple. It's not so simple as just turning off the inflammation. The idea is to turn off the inflammation at the right time. And in my mind, the question is also, how long do you turn off the inflammation for? Is colchicine one of those lifelong therapies? Is it only for a year or 2 years that you use this particular medication? So I really reserve colchicine for my patients who have a persistently elevated high sensitivity CRP, despite fixing all the upstream factors. They're remote from their event, and they have chronic coronary disease, and they continue to obviously be high from an ASCVD risk perspective. Certainly there's a label for pericarditis as well, but that's the 0.6 milligram dose. Now, remember, you don't want to go higher than 0.5 milligrams for secondary prevention because this could cause toxicity. You don't want to use it in patients with severe renal impairment, which is a GFR less than 30. And I would even implore you to say you even want to be careful using it in a GFR less than 60. Certainly can't use it if they have liver disease. You want to avoid concomitant use of strong CYP3A4 inhibitors. Certainly don't use it if they're allergic to it. Some patients can actually tolerate it due to the GI issues. In elderly patients, we have to be careful as well because they could have more side effects. And you don't want to use it during an acute gout attack if you're starting it for cardiovascular prevention. And then just keep a close eye on their renal function because you may need to stop the medication if their renal function starts to dip or if they're having any signs of muscle breakdown or anything like that. Be careful about those drug-drug interactions. And like I said, we still don't yet know what the optimal duration of treatment is. Is it for the rest of their life? Is it just until some of the underlying inflammation settles? It's a little bit unclear, but don't use it close to the event. You want to be at least 30 days out based on the fact of the Colcott trial, which was 30 days. So that's inflammation. We know that inflammation overlaps with all the other target signs like kidney disease. It overlaps with obesity. It overlaps with diabetes. It overlaps with sleep apnea, with HFpEF, with all the other CKM syndrome type of diseases. But certainly colchicine is what we've been thinking as the target for the final common pathway of inflammation. Okay, so now I'll just talk about icosapent-ethyl. And I know that a lot of people are asking me the question of, is there even a role for icosapent-ethyl in the setting of GLPs? Again, the Reduce-IT trial, which, talked about the 25% MACE reduction with icosapent-ethyl, was really in the pre-GLP era. It was before we put our diabetics on GLPs, and it was before we put our ASCVD patients on GLPs. And we know that GLPs can reduce your triglycerides. So I would argue that yes, if you've treated the obesity, you've treated the diabetes, you've treated all the other things, including diet, that raises your triglycerides, then icosapent-ethyl can be used in patients with persistently elevated triglycerides as a marker for risk, because we know again that it works on the atherosclerotic plaque, like complementary mechanisms to the GLPs and to the LDL reducing agents. So the way that I think about my patients with high trigs, the first thing I do is put them on a statin. The second thing I do, of course, is talk to them about diet, treat their diabetes, treat their obesity, get them off the alcohol, doing all that stuff, and their trigs are still in that 150 to 500 range. That's when you want to think about icosapent-ethyl as an adjunctive therapy, because we know that it can help to reduce total plaque volume. It can reduce vulnerable plaque. It can reduce the necrotic core. It can reduce non-calcified plaque, and it can make your plaque more stable by increasing fibrous cap thickness. A little different mechanism for what we saw in the GLPs. So it's really So amazing to have so many tools in our toolbox besides the LDL lowering agents, which are in the middle. But of course, now all these new agents that are looming on the horizon. And I haven't even started talking about non-steroidal MRAs. I haven't talked to you about gene therapy. I haven't talked to you about many of the other things. But to me, it's a really exciting time to be a preventive cardiologist because there's so much that we can do. So hopefully, I want to leave you today with a few pearls to take home, which is that number one, we need to do better because this persistent risk or residual risk that's out there, it's enormous. And we really need to figure out how to reduce our patients' cardiovascular risk much more aggressively because LDL isn't cutting it. So beyond LDL management in 2025, the first thing we need to do is to put target signs on our patient, use better risk stratification tools. Today, I presented to you the prevent equations, but where we're going in the future are polygenic risk scores and really a combination of using a calcium score or a low dose CCTA to screen our patients for atherosclerosis in combination with the polygenic risk score, in combination with epidemiologic data from equations like the prevent equations. That's where the future of predicting what's going to happen to us is headed. I know the AI technology is enormous right now. There's even something called a digital twin, where AI can basically create a twin based on your current biomarkers, based on your current imaging, and predict what's going to happen to you in the future. So I think we just got to be better about putting target signs in our patients using the tools that we have right now. Today, hopefully, I've also shown you that beyond LDL, there's many complementary ASCVD risk reduction pathways. Certainly obesity and metabolic syndrome, where we think about the GLP-1 receptor agonists and the SGLT2 inhibitors. Inflammation, so we want to check that HSCRP universally after we treat the obesity, the cardiovascular, kidney metabolic syndrome, and the diabetes. Similarly, the icosapentaethyl, if their triglycerides are persistently elevated after treating all those upstream factors. And then, of course, that lipoprotein A. Check it a single time in every patient in your clinic, no matter what they come in for, because that's how you're going to create population impact. So if they're coming in for PVCs, or they're coming in for something else, you check that lipoprotein A, you find that target sign, you outsmart that disease, and you do better. So I want to thank you so much for your attention, and I really hope you'll take some of these to heart and bring them to the bedside for your patients. Thank you so much.